Good day, everyone. My name is Anawari Victor. I am a neurology applicant, and I will be doing the Ching Cheng's comprehensive review in clinical neurology. We have done questions 1 to 38 so far, so good. And right now, we are about to do 39 to 43. Basically, we are more than halfway done with the chapter 1, which is on cranial nerves and neuro ophthalmology. So let us begin. We have question 39. A 45-year-old woman with mild hypertension presents to the emergency department with complaints of severe vertigo, unsteadiness, nausea, and vomiting. These symptoms began this morning, and she has had several exacerbations since then, each lasting about a minute or so, especially on neck extension. Examination is normal with the exception of nystagmus and nausea brought on by certain head movement. You are trying to decide if her vertigo is central or peripheral in origin. What will be the next step in evaluation of this patient? So this is basically a classic case of BPPV, benign paroxysmal positional vertigo. You have worsening of symptoms on head movement. This question does not show us any form of neurological deficits. And there is no neck pain, which means to just vertebral artery dissection. So this is basically looking like BPPV, but let's look at the options. So the option, this option, this question is not asking us what the diagnosis is. It's asking us what your next step in evaluation is based on your clinical reasoning. So we have a brain MRI to evaluate for stroke. So we've already said that it's unlikely to be a stroke because one, we have no cranial nerve deficits. We have nothing pointing towards a stroke-like symptom. Two, we have brain MRI to evaluate for acoustic neuromas or schwannomas. So for acoustic schwannomas, well, they may have vertigo, yes. They may have dizziness, yes. They may have nausea and vomiting, but it is not worsening on head movement. So that option does not seem right. Number C is Dick Halpick's maneuver. So Dick Halpick's maneuver is actually a maneuver used to confirm BPPV, especially posterior canal BPPV, but we'll still talk more about that. D. Avoiding neck rotation and disc maneuver until vertebral dissection is ruled out by neck MRI with fast saturation. Now, if this were to be a case of vertebral artery dissection, we would have seen other symptoms like maybe neck pain or what's not, but there's no neck pain in here, so it's very unlikely. And then we have Eppes maneuver. Now you should know that Eppes maneuver is actually a maneuver used to treat BPPV. It is not a maneuver used to diagnose BPPV. So let's do a little discussion. Whenever you see a case that is looking like the classical presentation of BPPV, a provoking maneuver should be done to evaluate for the presence of this disease entity. Now, usually you have a patient that has a history and examination that are less consistent of an acute stroke as seen in this patient. There is no history that is pointing towards a vertebral dissection. Neither is there a history pointing towards a slow growing acoustic neuroma. Now, BPPV is most commonly attributed to calcium debris in the semicircular canals. We call this the canalitiasis, and most commonly it occurs in the posterior canal. Now, these debris are actually loose autoconia, and they are made up of calcium carbonate crystals, which are within the auricular sac that have migrated into the semicircular canal. Now, the Dix-Hopkins maneuver is commonly done to diagnose benign paroxysmal positional vertigo. How is it done? So first, you have a patient seated, and then you basically extend the neck and turn it to one side. So let's assume you want to start with the right. So you turn the patient's head to the right while extended. Then rapidly, you bring the patient back down in a supine position and make sure that the head hangs over the edge of the bed, and you keep the patient in this position for at least 30 seconds. After 30 seconds, you then check the eye, or basically you look at the eye within that 30 seconds and to see whether there's going to be any form of nystagmus. Now, once you've done that, you then You then chill. If there is no nystagmus, you then return the patient back into his seated position and you observe them for another 30 seconds for nystagmus. And then you turn the patient's head to the other side. So let's assume the first time hit on the right. Next, you turn the patient's head to the left, slightly extended, and then you you rapidly turn them, place them in the supine position, and then wait for another 30 seconds to see whether there will be nystagmus. And if there's nystagmus, you notice down. If no nystagmus, you bring them back up, and then you observe for nystagmus. Now, this maneuver is actually very useful in diagnosing posterior canal benign paroxysmal position of vertigo, which is the most common form. And this nystagmus is usually characterized by upward and torsional beating. So we call it an upbeating torsional nystagmus. Now, after this, if you are able to elicit this nystagmus, after it stops and the patient is seated again, the nystagmus may actually occur in the opposite direction. We call that reversal of the nystagmus. Now, we should note that there are three other types of benign paroxysmal position of vertigo aside the posterior BPPV. So basically, there are four types of BPPV. So we've mentioned the most common, which is the posterior canal BPPV, but then there are three more, and they include one, the anterior canal BPPV, number two, the horizontal canal BPPV, and number three, the pure torsional BPPV. Now, the anterior canal BPPV, also known as the superior canal benign paroxysmal population of vertigo, actually has similar provoking factors as the posterior canal BPPV. But the difference is that the kind of nystagmus is actually downbeat instead of upbeat, and it's also torsional. Now, horizontal canal BPPV is usually provoked by turning the head while lying down and sometimes by turning it in the upright direction. So to elicit the nystagmus in horizontal canal BPPV, what you do is that you turn the head laterally in supine position rather than extending the head over the edge of the bed as seen in uh, the Dix-Hopkins maneuver. So the nystagmus is characterized by a downbeating towards the floor after turning the affected ear down. Usually it lasts for less than 1 minute, pauses for a few seconds, and then you have a reversal. Now, for pure torsional nystagmus, this may actually this may mimic a central nystagmus, and usually it results from canality access simultaneously involving both the anterior and the posterior canals, though it is less common. Now, it should also be noted that the pure canal BVPV tends to persist longer than other forms of benign paroxysmal positional vertigo. One key feature about central lesions is that there is absence of nystagmus latency. Now, central nystagmus has the following characteristics. So, one, it is non-fatigable. Two, there is absence of latency, which is the onset of nystagmus immediately after a provocative maneuver. Next, it is not suppressed by visual fixation, and the duration of the nystagmus usually lasts for more than 1 minute. It may also occur in any direction of gaze. Now, although pure torsional or vertical nystagmus is classically central in origin, pure torsional BPPV may mimic central nystagmus. Central vertigo is usually subjectively less severe than peripheral vertigo, but gait impairment, force, and unsteadiness are much more pronounced, and most often than not, you see other neurological signs. Hearing changes, tinnitus are usually absent. Now, but for peripheral nystagmus, you should note that one, it is generally characterized by fatigability with repetition, and usually they have a latency period lasting typically between 2 to 20 seconds. It is suppressed by visual fixation, and the duration of the nystagmus usually lasts less than 1 minute. It is unidirectional and usually horizontal, occasionally with a torsional component. Now, walking is typically preserved, although unilateral instability may actually exist. Hearing changes and tinnitus are much more common in peripheral nystagmus than in central nystagmus. So, when you have a unilateral peripheral vestibular lesion, such as seen in BPPV, what will happen is that you have asymmetry in vestibular activities. and this usually results in slow drifting of the eyes away from the target in one direction towards the affected side and away from the unaffected side, followed by a fast corrective movement to the opposite side towards the unaffected side, away from the affected side. So basically, what happens is that you have the eye, and then the eye slowly drift away towards the affected side. Yeah, and then you now have a fast corrective saccade away from that affected side to the unaffected side, and the amplitude of the nystagmus increases with gaze towards the fast phase, that is from the unaffected ear, so from the affected ear towards the unaffected ear. We call this the Alexandra's law. Now, peripheral nystagmus is suppressed by visual fixation, and this helps to differentiate it from central nystagmus. The treatment for BPPV is symptomatic, and it should begin with a particle repositioning maneuver, which consists of a sequence of head and body repositioning with the goal of moving the debris from the semicircular canal back into the auricular cavity. And the most commonly used is the airplace maneuver or the modified airplace maneuver. Now, it should be noted that there are other forms of maneuvers, and we're going to discuss that in another episode. Now, the airplace maneuver is actually the most efficacious for posterior canal repositioning, whereas anterior and horizontal canal repositioning often requires other maneuvers. Generally, self-treatment exercises should be given for patients to use at home. Post-maneuver activity restrictions, such as the use of cervical collars, maintaining the head right position for 2 days after treatment, which has been previously recommended, they have not shown any significant benefits from recent studies. Even the use of drugs like meclizine have not really been shown to be very effective based on recent studies. So we've already established that the answer to this question is options C, Dix-Hall-Pix maneuver, and we've established that this patient has benign paroxysmal positional vertigo. So for question 14, which of the following is most suggestive of a central vertigo? And let us try to recap the features of a central vertigo. So we said one, there is absence of nystagmus latency, and generally, if the absence of latency, that is suggestive of a central lesion. Remember that latency is the onset of nystagmus immediately after a provocative maneuver. We said two, the nystagmus is non-fatigable, so it is non-fatiguing. Three, it is not suppressed by visual fixation. Four, the duration is usually greater than 1 minute and it may occur at any direction of gaze. So let's look at our options. We have options A, suppression of nystagmus by visual fixation. That's false. Usually it is not suppressed by fixation. We have B, absence of nystagmus latency, which is true. In fact, this is actually one of the most important features of central vertigo. C, preserved walking with mild unsteadiness towards one direction. That's false. Usually when you have um, um, unsteadiness to one direction, usually suggestive of a peripheral nystagmus. Usually, yeah, a peripheral nystagmus or unilateral peripheral nystagmus. For horizontal nystagmus with the torsional component, that's false. That's actually very classical for peripheral nystagmus, which we'll actually see on, or peripheral vertigo, which we'll actually see in the next question. And then lastly, unilateral decrease in hearing, which is false. This is usually unilateral peripheral vertigo. So the answer is options B. Question 41. Which of the following is incorrect regarding nystagmus from peripheral origin? So which of this is not correct? First, the fast phase of nystagmus is directed towards the affected side. That is false. The fast phase is directed towards the unaffected side. So A is actually the correct answer. This is incorrect. Let's look at B. B. Nystagmus is suppressed by fibrous fixation. That's true. The nystagmus from peripheral is suppressed by visual fixation, unlike central, which is not suppressed by visual fixation. We have C. The amplitude of nystagmus increases with gaze directed towards the fast phase. That is true. D. The slow phase of nystagmus is directed towards the affected side. That is true. And E. The amplitude of nystagmus increases with gaze directed towards the unaffected side. That is true. So our answer is options A, which is the false one, which is incorrect. The fast phase of nystagmus is directed towards the affected side. And before we continue, let's not forget the Alexandra's law. which states that the amplitude of nystagmus increases with gaze towards the fast face, that is towards the unaffected ear and away from the affected ear. So for question 42, what is the pathophysiology of the disease process you suspect in this patient? So A is vertebral dissection, we've ruled that out already. B is acute pontine stroke, we've ruled that out already. C is acute infarct of the vestibular nuclei, we have ruled that out already. D is canalitiasis, which is correct, and E is acoustic schwannoma, which is wrong. So option D is the answer, canalitiasis. So next is question number 43. What would be the initial treatment at this time for this patient? So A, begin anticoagulation with heparin, that's no. B, referral to neurosurgery for schwannoma resection option, that's no. C, nasogastric tube placement to prevent aspiration until further evaluation is complete, that's false. D, decrease blood pressure to prevent dissection extension, that's false. And E, Epley's maneuver. Epley's maneuver is true, options E. So that leads us to a conclusion of this section. See you in the next session.